Hello everyone. Today we are going to talk about Wellens syndrome. Wellens syndrome is a critical pre-infarction state that indicates severe stenosis, often critical or near complete occlusion of the proximal left anterior descending coronary artery. So normally during stenosis of any coronary artery, what happens is there is formation of plaque which consists of lipids, macrophages, platelets and all. So all this plaque slowly form over the vessel and cause the thrombosis. Usually, MI or myocardial infarction occurs when there is sudden plaque rupture. That is, sudden plaque rupture if occurs, and then there is predation of this platelet, fibrin and all, and it causes the formation of thrombus there. And this leads to complete occlusion. So whenever there is complete occlusion, patient usually develop MI. Now, what happens is many of the times patient will have fibrinolytic agents. So these fibrinolytics naturally, which are present in the vessel wall or in the body, naturally lies this thrombus. So this lies the thrombus and there will be dislodgement of this main thrombus which has caused the complete occlusion. So again, the patency will be again maintained. So the blood flow starts again. So that means that there was MI, there was pain. Now the thrombus has resolved and some circulation has maintained. So patient has now become pain-free state. But some ECG changes has been persistent because there was some transient damage which leads to transient ischemic changes, which is usually present in the form of biphasic T wave. And if it persists for more longer time, then it may lead to deep T waves. So as you can see in Wellens syndrome, type A is called biphasic with initial positivity and terminal negativity. As you can see here, that is initial positivity of the T wave, and then there is negativity. It's called type A. Another part is called as type B, where there is complete deepening. So suppose time has elapsed, like more time has occurred from the occlusion, and there has been recanalization. There will be deep T waves which can see, and this is called as type B Wellens syndrome. So often, why this is so important is that often people tend to make mistake that since there is no chest pain, they stop evaluating these patients. So that is should not be done because here you have actually dissolved the thrombus, but the plaque is still there. That means that there is high chances that this plaque, that too, this is unstable plaque because it has already ruptured once and this is freely exposed. So there is more chances of thrombus again formation over here, this part. So that's why this thrombus can again, this plaque can again rupture, or this is more can expose to again with the thrombus and fibrin and can reocclude the artery and can lead to convert into massive MI or massive STEMI if you don't treat or evaluate this patient. So all this patient of Wellens syndrome has to be taken very seriously and has to be immediately taken for emergency coronary angiography. Coming to ECG changes, as we have discussed, there was deeply inverted or biphasic T wave. ECG pattern is present during pain-free state. The patient is no pain because the main thrombus has dissolved. And there is ST segment elevation is there very minimal or less than 1 millimeter. There is no precordial Q waves. That means the pathological Q waves is not there because there is no permanent infarction, because there is no permanent damage, because there was some occlusion and which is transiently now has cleared. So the supply is being maintained. So there is no permanent damage and thus there is no precordial Q waves. Also, there is preserved precordial R wave progression because no damage to the myocardium. And recent history of angina will be definitely will be there. So patient may come to you OPD with no chest pain, but he must be having a classical angina symptom at home whenever he had that. So markers could be either normal or slightly elevated because only there was transient time when there was supply was not matched. So there could not have been a sufficient myocardial damage to release the biomarkers. So coming to step-by-step method mechanism, initial event was transient left anterior descending artery occlusion, as we discussed. Again, there is reperfusion phase either because of spontaneous clot lysis or administration of pre-hospital aspirin, which can restore the LAD perfusion. So chest pain usually resolves, but there is so ST elevation must have been there when there was complete occlusion. Now the ST elevation has subsided because there is no pain and thrombus has resolved, and there will be biphasic or deeply inverted T waves. T wave then evolution over time, that is, if LAD remains patent, so T wave gradually evolves from biphasic to deeply inverted. And suppose a patient after this thrombus, like plaque, and the thrombus is resolved, again the thrombosis forms here. So how will you suspect that patient is having reinfarction? Is that so initially as a trail there is T inversions. See, these T inversions will now start getting normal. That means that if this is P, Q, R, S, and we are seeing that this is biphasic T wave here. So this T wave, if it starts getting normal, that itself means that there is reinfarction. This is called a pseudo normalization. So if T wave is again coming to up, normally upright, becoming upright, that itself means that there is reinfarction which is happening, and patient may immediately land into hyperacute STEMI. So full-blown anterior wall MI can occur. Also important is that in patients with Wellens syndrome, there is stuttering pattern, that is intermittent occlusion reperfusion. So this episode of occlusion and reperfusion can occur multiple times. So patient may have chest pain, again resolves, again chest pain, again resolves, because the plaque is very unstable. So thrombus is forming here, fibrin is depositing, it is automatically getting clear. Again fibrin is depositing, again it is getting clear by the natural fibrin clot lysis system. So usually very commonly it is seen in anterior leads, but it is not restricted to that. Sometimes it can also be seen with inferior leads or lateral leads. And all the time it is not necessary that it is only thrombus only. Sometimes it can be because of coronary vasospasm as well. Spasm. Or it could be because of just formation of without plaque, there is only formation of thrombus also. But these are very less chances. And if we keep suspecting that it could be because of vasospasm and thrombus, and if you do not evaluate, and supposing there is large plaque which is present, if it converts into STEMI, you may lose the patient. So always better to be on the safe side and do immediately take the patient for coronary angiogram. So always assume critical LAD stenosis, prompt evaluate with angiography even if the patient is currently pain-free. Thank you.